We are live.
Good, okay. Good evening, delegates and participants. Thank you for joining Shield Connect. And today, our Fetal Medicine Committee, MOGS, and Aurangabad Obstetric and Gynecology Society brings you with a new topic. On the topic is ultrasound update. And let me introduce our MOC, Dr. Sunita Khedkar, ma'am. Dr. Sunita Khedkar, ma'am, is the consultant and director of Khedkar Maternity Hospital since 14 years. Ma'am has been ex-registered at Vadia Maternity Hospital, Mumbai, and ex-consultant at MIT Multi-Speciality Hospital, Aurangabad. Field of interest is obstetric, sonography, infertility, and menopausal health. So I hand over the session to Dr. Sunita, ma'am. Thank you, ma'am.
Thank you for the kind introduction. Now I will invite Dr. Sujit Konkar sir. Can we have CV of Sujit Konkar sir? Sujit sir has done his MBBS and MD from GMC Aurangabad. He has done his basic USG training at Bimal Sahani sir Sonoscan Center Aurangabad. He is FMF certified at 11 to 13 week scan, preeclampsia screening, Doppler ultrasound, and fetal abnormalities. He is secretary of Society of Fetal Medicine Marathwada chapter. He is director and consultant at Sri Hospital, which is a Foxy certified USG training center. He is interested in advanced fetal and ultrasound. He is currently chairperson of Fetal Medicine Committee MOX. I request Sujit sir to welcome all the delegates and give his speech.
Join sir.
I request Sujit sir to welcome the delegates.
Thank you, Dr. Sunita, for a nice introduction. I am very much delighted to give welcome speech for this webinar. First and foremost, I welcome our chief guest, respected Dr. Kavita Bapat ma'am, for this webinar. Your words will be having very great value, ma'am, for this webinar. I welcome Dr. Rajan Singh Pardesi sir. He is yet to join. He will be joining now for this webinar as guest of honor. I welcome our esteemed faculties, Kuldeep Singh Sarji. Please welcome Dr. Archana Patil. She is yet to join. I welcome Dr. Anjali Vare ma'am, President Aurangabad Obstetric Obstetric Society for this webinar. And last but not least, I welcome all the delegates who have just joined, logged in for this wonderful webinar. The topics today are diversified. I will be talking on fetal thorax. Dr. Kuldeep Singh sir will be talking on the fetal face, and Dr. Archana will be talking about something placenta and all those things. So, Dr. Sunita, please take over for further proceedings.
Thank you, sir. Now I like to invite and introduce Dr. Kavita Bapat, madam. We all know her. She is past Vice President Foxy. She is organizing secretary of AICOG Indore, director at Bapat Hospital Indore. She is one-day hysterectomy specialist and she has ICOG vaginal surgery certificate course center. She is Jogi peer reviewer, editor, Apollo Medicine. She initiated registry of primary ovarian insufficiency. She is president of Indore Menopause Society, vice president of MP chapter of vaginal surgeons. Thank you, ma'am, for joining us. I'll request you to say a few words of wisdom for us.
Thank you so much. Thank you so much. Really, I'm really happy today. Actually, Dr. Pardeshi is with me joined there, but Dr. Pardeshi is really a person who has made as a president AMOX. He has achieved some certain different levels. Sare committee chair, everybody works so well under the guidance of Dr. Rajendra Singh Pardesi. So I am so really happy today. And thank you so much, Sujit, for remembering me and making me guest of honor today. You are also working and doing this program in such a nice manner, at least in such a systematic and such a proper manner. You called me, you invited me, you followed me, again you did it. So I'm so proud of you, really happy. The subject and you are having the great speakers today. Actually, once you see the Dr. Kuldeep Singh, so all the chapters of ultrasound, what he has done in a COVID to teach the people ultrasound, I think it has reached to the each and every home. Like my matter is every member matter. Same with you, sir, that you have taught ultrasound to each and everyone simply. And Sujit is also helping you out. And another is Archana Patil is there. And Anjali, thank you so much as the President AOGS and Secretary Vaishali for inviting me to the Aurangabad. But ultrasound, ultimately, I'm really worried for a few things, sir, in future. This ultrasound should not be taken up over by the artificial intelligence in the future. That's a big thing, but the man behind the machine is more important than the machine, as I always talk about, because people लोग कहते हैं कि vessel sealer खरीद लिया तो कोई भी vaginal surgery कर लेंगे. It should not be like this. Same with the person behind the machine is very, very important. So when to refer the patients to the fetal medicine specialist at the 18 weeks, do every sonologist should do the fetal echocardiography or not to do, and when to refer, and so many things are there. So I'm really happy today, Sujit, that you are doing the update on the ultrasound, and for this seminar, I think this webinar will help to all the audience which they are going to soon. And I'm sure Kuldeep sir, Bate, Archana is there, and you are there. There may be lot many audience, and lot many will be people will learn today. So and thank you, Sunita, for giving the prize word. Thank you so much for inviting me today. Thank you so much. Okay. Thank you, Anjali and Sunita and everyone.
Yes, okay, ma'am.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Pardeshi sir is yet to join. I'll also like to invite and introduce Dr. Rajendra Singh Pardeshi sir. He is yet to join. Till that time, I'd like to welcome Dr. Anjali Vare ma'am. Anjali Vare ma'am has done her MBBS and MD from GMC Aurangabad. She is currently president of Aurangabad OBGYN Society, consultant at Vare Hospital since last 27 years. She is interested in high-risk obstetrics and sonography. She has conducted many adolescent health camps in schools and colleges. She has worked in obstetrics HGU. Welcome, ma'am.
Thank you, Sunita, for your kind words. Now I think I should introduce Sujit, and we will start with the,
Yes, ma'am.
Yeah.
Yes, yes.
okay. I will like to welcome Dr. Sujit Konkar. He has done his MBBS and MD from the GMC Aurangabad, and he has taken basic USG training at Dr. Bimal Sahani Sonoscan Center. And he is a FMF certified for 11 to 13 week scan, PE screening and Doppler ultrasound. He is the secretary of Fetal Medicine Marathwada chapter, and his Shri Hospital is FOXA approved for USG training. And he is interested in advanced fetal ultrasound, and he is a chairperson of Fetal Medicine Committee, AMOX, and he is one of the best sonologists in Aurangabad. Welcome, Sujit. Please start with your talk.
Thank you, ma'am, for a nice introduction. I'm going to share my screen now. Yes. At the outset, I would like to thank AMOX, President Dr. Rajendra Singh Pardeshi sir, and Secretary Dalve ma'am for giving me this opportunity. The topic today is ultrasonographic evaluation of fetal thorax. Fetal thorax is the upper part of trunk. It is supported posteriorly by spine and on either side by ribs. It is separated from abdomen by the diaphragm, and it contains various important organs like heart, lungs, and other mediastinal structures. So whenever we talk of normalcy of fetal thorax, here we have some questions. Are the supporting structures normal, like ribs and the posterior spine? Are internal organs in normal position, like heart in leocardia, both lungs and vessels? Are internal organs normal? Are there any masses, cysts, or fluid? Are there any thoracic wall defects? So this comprises all thorax, but the major glamour of the thorax is taken away by the one organ, that is fetal heart. We talk so much about fetal heart. There are so many talks, so many conferences about fetal heart, but one thing is neglected, that is fetal lungs. So I'm going to talk about lungs and here the common pathologies. So here I want to stress some basic important things. First one is that the echogenicity of lung is higher than the liver, slightly higher than liver. And second one, the echogenicity goes on increasing at the gestation age advances. So this is the fetal lungs at 13 to 14 weeks of gestation. You can see the echogenicity. Compare with this. So the echogenicity at 20 weeks is much better, much more than as compared to the echogenicity at 13 to 14 weeks. And this is a normal physiological phenomenon. So beginners may be confused or may label this as a pathologic, but it should not be happen. And second one is the extent of ribs. See the ribs should always cross the crux of heart. This is the normal size ribs. Of course, we are not going into details about ribs today. We are looking at lungs only, but this point should be remembered. So pathology of fetal thorax can be divided into two groups. It can be intrinsic pathologies or extrinsic pathology. Intrinsic pathologies being CPAM, bronchopulmonary sequestration, and chaos. Extrinsic pathology is important. That is only one pathology, that is congenital diaphragmatic hernia. So whatever be the pathology, any intrathoracic mass, whether it is intrathoracic or coming from outside like CDH, it affects the prognosis by pressurizing the mediastinal structures and giving rise to head offs and some amount of pulmonary hypoplasia. So we are going to look in this manner in all the pathologies. So coming first to congenital diaphragmatic hernia. It is the developmental discontinuity of diaphragm where there is herniation of abdominal viscera into the thorax. This herniation is not the problem, but we are more worried about the lungs, because this herniation and this pressure causes two important worst thing to the lungs, that is pulmonary hypoplasia, and second is pulmonary hypertension. The lungs starts developing from 3 weeks to, and it's completed at 14 to 16 weeks. And the herniation occurs during this critical period of lung development. And this mass effect causes loss of bronchial branching and pulmonary mass, resulting in pulmonary hypoplasia. And there is overmuscularization of pulmonary vasculature, resulting in pulmonary hypertension. There are various causes of failure of closure of pleuroperitoneal floats between 4 to 10 weeks. Some are genetic causes, some are environmental causes like vitamin A deficiency or ingestion of some drugs. But genetic causes are important. There are some aneuploidies like Downs, some translocations, some fetal syndromes are also associated. So whenever we cross a case of congenital diaphragmatic hernia, genetic evaluation is must. This is a schematic image of diaphragm with two important foramina causing the defect. Posterolateral foramina, these are the foramina posterior, and the anterior midline is foramina Morgagni. So whenever there is a defect at foramina posterior, you get on left side stomach and bowel as intruding structures, and on right side liver. And if there is defect at foramina Morgagni, which is rare, you get anterior midline structures like stomach, bowel, and liver as including structures coming into the thorax. Left-sided hernias are most common, comprising almost 80%. Right-sided hernias up to 10 to 15%. And bilateral hernias are rare. They constitute only 3 to 4%. And if there is complete agenesis of diaphragm, here the diaphragm is replaced by fibrous tissue. It is called as eventation of diaphragm. It is also very rare, but it is sonographically, it is very difficult to differentiate between congenital diaphragmatic hernia and eventation. But prognosis wise, eventation is far better diagnosis than congenital diaphragmatic hernia. And remember that congenital diaphragmatic hernia is a progressive disorder. The defect is there since its development at around 12-14 weeks, but the herniation can occur anytime during pregnancy. It can occur in first trimester at around 20 weeks, it can occur at 30 weeks or at term, or even in some cases, the herniation can occur only after birth with the first breath. So if your 20 weeks scan is normal and at 30 weeks somebody diagnosed congenital diaphragmatic hernia, don't blame yourself that you have missed it. You are not missed because there was no herniation. It is very difficult to delineate or mark the integrity of diaphragm on ultrasonography. It is a schematic representation of the hernias. See here in left-sided congenital diaphragmatic hernia, the content are stomach and bowel and sometimes liver. And in right-sided hernia, the contents is most of the times liver. In left-sided congenital diaphragmatic hernia, there are 4 possibilities: stomach up, stomach down, or liver up or liver down. Stomach up condition is very easy to diagnose because in a routine axial scan of abdomen, we don't get stomach at this normal position, and you have a cystic lesion in thorax, that is stomach, pressurizing or displacing the heart to other side. This is the easiest diagnosis. But the problem and difficulty in diagnosis is when the stomach is down and there is echogenic structure shifting the heart to other side. And this is nothing but this is herniation of only intestines, and stomach is normal in the abdominal cavity. What are the clues to suspect this? There are few clues. There are two important clues. One is elongated stomach. As there is stretch of intestines upwards, the stomach has gone downwards. It becomes elongated. At times, it can reach up to pelvis. This is one sign. And another is the course of superior mesenteric artery. See, normally superior mesenteric artery which supplies the intestines is coursing downwards like this. But when the intestines are pulled up into the thorax, there is upward course of superior mesenteric artery as shown in this figure. So here, when stomach is down, the echogenic structure is there in the thorax beside heart. We have to rule out other differential diagnoses like congenital pulmonary airway malformation or sequestration. Again, liver up, liver down is okay, but when do you suspect liver up? There are a few points here. The position of stomach is important. Gradations are available from grade 1, grade 0, grade 1 to grade 4 about the herniation of stomach. So here you have to see the extent of stomach in relation to crux of heart. If the stomach is seen posteriorly, as shown here, it is going behind the heart and going past the crux, then you can suspect the liver here, anterior side. Another sign is that you can see the hepatic vessels going into the thorax, as shown in this figure. At times, you may get gallbladder in thorax. And another indirect important sign is the umbilical vein. This is the normal umbilical vein. When after entering into the abdomen, it is coursing towards the right side, away from stomach, almost making a 90 degree. But whenever the liver is up, it is stretched. The umbilical vein becomes straightened like shown in these two diagrams. So these are the indirect clues which tells you that the liver is up into the thorax. So whenever you come across the case of congenital left hernia, always look for the anomalies in other systems. Commonest and most important is cardiac anomalies. CDH is also associated with various aneuploidies like Downs, trisomy 21, 18, and 20, and 13. Various syndromes are associated like Fringe syndrome, Alistair-Killian syndrome, Beckwith-Wiedemann syndrome. So whenever there is case of CDH, genetic evaluation is compulsory in these cases. And another important thing which we should not be worried about is the functional aortic stenosis. There is cardiac compression because of this mass effect of the incoming structures. So there is a disproportion between left ventricle and right ventricle. So left ventricle looks smaller, mimicking hypoplastic left heart syndrome. But this is the functional thing, and the outcome is not bad in these cases. It is good. Now coming to prognosis of congenital diaphragmatic hernia. So the group of Kapros-Nicolaides has written this nice article regarding prognostic factors of congenital diaphragmatic hernia. So these are the sonographic signs which tell us the diagnosis of prognosis of CDH is worse. That is presence of polyhydramnios. That means there is too much pressure on the esophagus. Presence of associated anomalies. Early diagnosis. That means diagnosis done in first trimester. Large volume herniated. Mediastinal shift. That means mass is more. And right-sided diaphragmatic hernia where there is herniation of liver. But by and large, there are two important things when we think of prognosis. One is LHR, that is lung area to head circumference ratio, and other is liver herniation. LHR, that is lung area to head circumference ratio, is calculated in contralateral lung. You can have two ways of calculating it. You can use line trace method as shown here, or you can use anteroposterior and transverse diameter. Line trace method is supposed to be superior, but you can accept or do whatever you are comfortable with, and various calculators are available for that. So when LHR is more than 1.4, the prognosis is good, survival is good. If it is less than 1, the prognosis is bad. And if it is between 1 to 1.4, these babies may require ECMO, that is extracorporeal cell membrane oxygenation after delivery. But there are some drawbacks of LHR, because it is not GA dependent. Here, the head circumference acts as a surrogate for gestational age. Remember that lungs and head grow at different rates. For example, we compare the difference, the rate at 12 weeks to 32 weeks. There is 4-fold increase for head circumference, while there is 18-fold increase in the area of lungs. So here are two different things growing in different velocities. So the accuracy of LHR is questionable. And another important point is that it is not used in right-sided congenital diaphragmatic hernia. So LHR was done till now, but to overcome drawbacks of this LHR, a new entity has come, that is O/E LHR, that is observed to expected LHR. Here, the LHR of the index case is measured, and it is expressed as a proportion of LHR, which is seen in normal patients at that gestation, normal base of that gestational age. And it is, of course, gestational age dependent. It can also be used in right-sided congenital diaphragmatic hernia, and the best period to measure is 24 to 26 weeks, because we measure it at 19 weeks or 20 weeks, and if it is a good LHR, but if herniation occurs after that, then your prognosis and all the measurement will go in wrong way. So when O/E LHR is less than 15%, it is bad sign. There are no survivors. And as the O/E LHR goes on increasing, the survival rate goes on increasing. And if it is more than 45%, it is very good sign. Almost all babies survive. Again, this is the prognosis relating to liver. This is a very nice article about liver herniation. In one sentence, you can tell that if there is liver in thorax, the prognosis is not good. Prognosis is bad. So prognosis wise, there are three groups: two isolated groups and one is as an associated group. In isolated group, if the CDH is late onset, that means diagnosed late, liver is down, and LHR is more than 1, then the survival rate is more than 60%. If it is early onset, that is diagnosed in first trimester, liver is up in the thorax, LHR is less than 1, and the survival rate is less than 30%. And worst thing is if there are associated anomalies, associated aneuploidies, associated syndromes, the survival rate is less than 10%. There are newer indicators for prognostications and quantifying the CDH. You can use MRI and 3D volumes. Gradations of liver herniation are available for MRI. You can use qualitative lung index, but by far at present, O/E LHR is the best and most productive way to prognosticate the congenital diaphragmatic hernias. And again, you can use the assessment of pulmonary artery hypertension for prognostications, where you see the size of pulmonary branches. McGoon index is widely used, which is lower in abnormal cases. When coming to management, there are three options: termination, conservative management till term, or FETO, that is fetoscopic intraluminal tracheal occlusion. And all this is decided by O/E LHR. If O/E LHR is less than 15%, prognosis is bad, survivors, there are no survivors. So in these groups, you can opt for termination of pregnancy. And if it is more than 45%, prognosis is good, almost all babies survive. Here, you can wait and conserve the pregnancy till term with good follow-up every month, whether it is progressing or not. And FETO is required for this midline group from 15 to 45%. FETO is nothing but you put an intratracheal balloon here, it is inflated, it obstructs the trachea, and it causes the proliferation of distal alveoli and lung tissue, creating artificial chaos. Next thing is CPAM, that is congenital pulmonary airway malformation. It is the commonest lung lesion, almost this 59% of all prenatal lung lesions. It is the imbalance between lung proliferation and apoptosis, giving rise to unchecked proliferation and growth of this alveoli. It is connected to the tracheobronchial tree. This Waters classification, microcystic variety, that where there are cysts more than 5 mm, which is commonest. Second commonest is mixed variety. And third one is the macrocystic, where there are more than 5 mm cyst. So coming to ultrasonographic diagnosis, this is the echogenic or cystic mass, usually in the lower lobe of liver, and mostly it is on unilateral, and the mediastinal shifts depend on the volume or size of the mass. So here, this is the lesion in right lung. This is the microcystic variety of the CPAM. Here in this image, these large cysts, they are pressing the displacing the heart to another side. But the crux of diagnosis of CPAM is the blood supply. Here, as shown here, the blood supply to CPAM is from the pulmonary vasculature, and this thing differentiates it from the sequestration. Naturally, the maximum growth of CPAM is between 20 to 25, 26 weeks. It is highest at 25 weeks, then it plateaus. And there are then two ways they behave. More than 50% of cases, the CPAM is resolved in utero, mostly in cases of microcystic variety. And in remaining cases, it is that goes on increasing, causing mediastinal shift and head drops. So there is one argument that these CPAMs are not resolving because of it is giving false picture resolution because of increasing thoracic size in comparison to mass, decreasing echogenicity with gestational age, and increased echogenicity of the surviving lungs. But if you measure the mediastinal shift from initial to advanced stage, you may find that there is definitely decrease in the mediastinal shift, and it is true that CPAMs are resolving. And there are two theories to support that. They outgrow their blood supply, and there is spontaneous torsion shutting their blood supply of its own. Remember that resolution is common in microcystic variety. And risk of head drops in CPAM is determined by two things. One is gestational age and other is size. As told earlier, the rate of growth is highest in 20 to 26 weeks of gestation. So if the CPAM is diagnosed in this period, you have to look carefully for head drops and again size. So the bigger the size, bigger the mediastinal shift, and the chances of head drops are more. And it does not depend on the type of CPAM. And whenever there is head drops, sadly, the mortality is 100%. So how to prognosticate CPAM? How to quantify it? So there are various methods, that is CVR, that is CPAM volume ratio. Another is mass volume to estimated fetal weight ratio. You can use MTR, that is mass to thoracic ratio, and to some extent you can use LHR in these cases also. CVR is calculated by multiplying height and true posterior diameter, transverse diameter, and constant factor 0.52 divided by head circumference. Here you should remember two numericals. One is 1.6 and other is 0.9. If CVR is more than 1.6, there are high chances that this baby may land in head drops. And if it is less than 0.9, the outcome is favorable. Remember that CVR is useful only in microcystic variety and not useful when there is large cyst. When to call the follow-up? You can call for follow-up either weekly or monthly depending on the gestational age and CVR. As the maximum growth is from 20 to 26 weeks, and the CVR is more than and the gestation is between 20 to 26 weeks, you can call the patient for weekly follow-up. Once it has crossed the 26-28 week window, then growth of CPAM is slow, the CVR is also less, and you can call this patient monthly for follow-up. There are various types of intervention in CPAM. You can use steroids, thoracocentesis, thoracoamniotic stent, and resection of mass. But practically more useful are steroids and thoracoamniotic shunt. Thoracocentesis is also useful and can be productive, but in many cases, there is a reaccumulation of fluid in the cyst. So again, we have to repeat the procedure. Resection of mass is not an easy thing. You need laparotomy for that. Steroids, they are useful in microcystic CPAM. The dose is same as what we use in for lung maturity, that is 12 milligram betamethasone, 24 hours apart. Maximum 2 courses can be used. You can use 3 to 4 courses as shown by various other papers also. Thoracoamniotic shunting is also a good option. It is used in microcystic lesion where there is a large dominant cyst. It should not be used before 20 weeks to avoid the injury to thoracic structures. Next one is bronchopulmonary sequestration. It is different from CPAM because it is a segment of lung with non-functioning lung mass. It is having systemic arterial supply and it is not connected to tracheobronchial tree. Most commonly, it is seen in left side of the lungs, left lower lobe, almost in 90% of cases, and it may decrease in size during gestation. Here are two types of bronchopulmonary sequestration, intralobar or extralobar. Intralobar is seen within the normal lung. It is covered by visceral pleura of lung and it drains into pulmonary veins, while extralobar are there outside normal lung, has its own visceral pleura and it drains into systemic veins or at times pulmonary veins. Extralobar does not necessarily mean that extra thoracic. Even in the thorax, you have extralobar, but they are having their own pleura. Natural history of sequestration is far better as compared to CPAM. 75% of bronchopulmonary sequestration, they decrease in size. Head drops is very rare. Head drops is because of two reasons. One is mass effect and second is there are some AV shunts within the tissue. So here, because of mass effect, there is some hydrothorax here. So whenever you see echogenic lung and with microscope, with hydrothorax, it is 100% extralobar thoracic BPS. That is hallmark of bronchopulmonary sequestration. So CVR can be used to quantify the amount of BPS, but it is not as predictive as CPAM. You need close follow-up. It is important when it is giving pressure symptoms and head drops. There are two important differentiations for infradiaphragmatic BPS. One is adrenal hemorrhage and neuroblastoma. The differentiating features are when we think of adrenal hemorrhage, see here, this is a nice image of adrenal hemorrhage. This is the kidneys, and you see the cystic lesion sitting on the top of the kidneys. The adrenal hemorrhage change appearance with the time. Initially, it is echogenic, then it becomes hypoechoic, then it becomes cystic. And at times, after few days, you may get calcification that. And it is the third trimester diagnosis with no feeding vessel. In bronchopulmonary sequestration, there is single feeding vessel is almost always seen. And another thing is the neuroblastoma. Most of the times, neuroblastomas are right-sided. They can be cystic, and it grows with gestational age. This is also a third trimester diagnosis. This is very nice video clip of extralobar BPS, courtesy to Dr. Manoj Jadhav, a friend from Barshi. So you can see the location of this echogenic mass. It is below the diaphragm. It is not in the thorax, below the diaphragm, between the heart and the midline. This is very nicely seen. See in this axial view also, see fourth chamber view don't show anything. And if you go below that, you see beside the stomach, this is the echogenic lesion. And next thing, when color is put on, you see a vessel is going into the lesion from the aorta. The blood supply to this lesion is from the aorta. This differentiates it from the pulmonary sequestration. Of course, this is extralobar thing. This is nothing but pulmonary sequestration. And in this coronal view, the blood supply is very nicely demonstrated. See, this is the coronal view. These branches are going into the lesion. This was a classic case of extralobar bronchopulmonary sequestration. In BPS, the intervention is rarely required. But if it is mixed lesion along with CPAM, you can use steroids or shunt. If the BPS is causing head drops, pressure changes, you can use laser coagulation of the feeding vessel to decrease the size of that mass. Coming to chaos, that is congenital high airway obstruction. It is the partial or complete obstruction of upper airways, mostly involving larynx. It is usually incompatible with life. See, the three important sonographic features are bilateral enlarged echogenic lungs, as shown here in these diagrams. Dilated distal airways, see in this figure, their trachea and bronchi are dilated, and the flattened inverted diaphragm. In these two images, the diaphragm is flattened. These two things, dilated distal airways and flattened inverted diaphragm, these are the hallmark of chaos. It is incompatible with life. Bronchial atresia, it can be labeled as unilateral chaos because one-sided bronchus is obstructed. Again, there are enlarged echogenic lungs on one side. You can see the dilated bronchi, and mediastinal shift causes features of polyhydramnios or head drops here also. Coming to last thing, pleural effusion, that is hydrothorax. It is the accumulation of fluid in pleural space. It can be primary or secondary. It can be bilateral or unilateral. Antenatal primary hydrothorax typically corresponds to congenital chylothorax, and secondary hydrothorax usually is a part of non-immune hydrospitalis. So primary hydrothorax is diagnosis of exclusion, and secondary hydrothorax is always with non-immune hydrospitalis. You have to look for other systems like cardiac anomalies and arrhythmias, various lung lesions as described just now, so mediastinal tumors, congenital goiter, congenital infections like torch and fetal parvovirus infection, fetal-maternal hemorrhage and fetal anemia. Some chromosomal aberrations are associated like Downs and Turners. In some cases, autosomal or X-linked recessive inheritance is also found. The prognosis of pleural effusion depends on degree of pulmonary hypoplasia and underlying cause. If hydrops is there, our prognosis is not good. Outcome, almost 10% of the babies die in utero, 20% land in neonatal death because of various syndromes and pulmonary hypoplasia, 30% survive with morbidity, and almost 50% are normal, and these are the isolated cases, that is primary chylothorax. So coming to treatment part, You can manage conservatively if the effusion is small, which is not increasing. You can use antenatal thoracocentesis, but problem again here is that it can reaccumulate after 48 to 70 hours, 72 hours. Pure amniotic shunting is best. It gives continued drainage. You can use some sclerosing agent for pyrodesis. OK 432 or maternal blood has also been used for that. To conclude, whenever there is echogenic lesion in lung, you have to go stepwise diagnosis, stepwise analysis for diagnose whether it is intrinsic, like CPAM, BPS, and all these are extrinsic, like congenital apharid hernia. Whenever you are diagnosing CDH, look for other system anomalies and go genetic evaluation is must. Prognosticate the things by using LHR, O by LHR, and CVR, because the correct diagnosis can be difference between the life and death. Thank you for being online. I think I finished in 25-30 minutes.
Congratulations, Dr. Sujit. It was an excellent talk. Thank you. Thanks a lot.
Nicely narrated.
Thank you, sir.
All the and PPT.
That was really in detail discrimination of. Yes, sir. Very much within the. Yes.
Fantastic coverage of the whole topic. Excellent.
Everything very nicely covered. Now we'll move to the next speaker. I'd like to invite and introduce Dr. Kuldeep Singh, sir. Yes, yes. Now I'd like to invite Dr. Kuldeep Singh, sir.
I think so. We've lost connection. Dr. Sujit, you can just introduce and then we can start off.
Yeah.
Dr. Sunita is back. She's back.
Okay.
Can you have CV of sir? Kuldeep Singh, sir? Yes. The topic is fetal phase. USG mirror says it all. It's my privilege to introduce Dr. Kuldeep Singh, sir. He is master trainer in field of ultrasound. He practices ultrasound in New Delhi with excellent skills in ultrasound in obstetrics and gynecology and infertility. He had given more than 300 talks at various national and international platforms. He has 4 awards to his credits and 3 gold medals in the field of ultrasound. He has authored 16 books on USG in OBS and infertility. His books have been translated to various languages. He is awarded Imaging Science Award in
Your voice is not audible now.
Sonography. Welcome you, sir.
Thank you. Thank you, Dr. Sunita. Thank you so much. Thank you, Dr. Sujit, for inviting me. Thank you, Dr. Kavita ma'am, for it's always a pleasure to be with you and having all these webinars. I'm so glad. And we're going to start off with the basically the topic today is fetal phase. The ultrasound mirror says it all. So I know whenever we say about fetal phase, everybody wants to know about, okay, let's have some 3D and 4D. So I'm going to start with a few videos on 4D, and then I'm going to come up with the specific topic. I hope everyone can see the screen. Can you see the video running?
Yes, sir.
Yeah. Perfect. So you can see the
Yes, sir.
various.
Yes, sir.
Thank you so much, ma'am. There you're looking at various things that you can see over here. The various aspects, even the third trimester that we've started looking at the fetal phase. We have a LinkedIn poster of this also. The many of you must have gone through that. I'm just putting up some experts from there, just baby yawning, baby smiling, the eyelids moving over there. There, that's the yawning. That's going to happen when I'm going to be almost finishing my talk. There. That's when the talk gets finished, everybody starts smiling. Ki, haan ji, theek hai ji. I'll just show you a few more things and then we start off with the topic. That's the baby rubbing the eyes. There. The suckling reflex, all that starts off in the third trimester itself. And this is very, very useful for looking in for that. I'm looking at a normal fetal brain over there. I'll just show you this very carefully. See the eyelids opening and closing. You can see the movement of the eyelids over there. You can nicely see the nostrils, and it's always a pleasure for the parents because once they see this, they're absolutely comfortable, and there's so much more that we can be happy about. There. So I'm going to stop. There, look at that. So we're going to now start off with the talk portion. The fetal phase, I hope the slides are moving now. The fetal phase, the ultrasound mirror says it all. Thanks to Dr. Sujit again for suggesting this topic. And that's when I really figured out that there's so many things which we could do that on the fetal phase. Well, why are we so hassled about the fetal phase? Because it causes extreme parental distress because of it being so visible. Imaging at 16 to 18 weeks can delineate plenty of detailed facial anatomy. Well, we always have our do's and don'ts when we're looking at oligohydramnios, maternal obesity, especially the fetal position. That's what I tell everybody. Never and never presume that the things are going to be fine till you've seen with your own crooked eye. That's extremely important. We have 3D to help us, but that's not the ultimate. That's what the information I want to give. There are going to be so many things which we're going to be looking at on a 2D ultrasound. 3D is always helpful, but it does not mean that if you don't have a 3D, you'll not be able to figure out about facial anomalies. What all can you really look in for? You start off with the NT scan portion. There you're looking at a profile. You can look in at the nasal bone, the echogenic tip of the nose. You're looking at the nasal skin over there forming an equal to sign. You need to be watchful for that. Nasal bone, nasal skin, echogenic tip of the nose. You can see a normal profile, the maxilla and the mandible seen over there. These your guidelines. We're supposed to be looking at all this. And now you need to remember, I'm going to tilt myself a little bit. You're going to be seeing, we can have, for everything, we can have 3 views. We can have an axial or a transverse view. We can have a longitudinal view and a coronal. Let's presume I am a fetus. You can have over here a transverse or an axial section for the fetal orbits, for the maxilla, for the mandible. You need to look in for the profile view. You need to be looking at like this. I hope it's coming over there. You're going to be cutting your face like this. Then you need a coronal plane. You're going to be cutting your face like this. That's a coronal plane on a 2D. And if you need to be looking at a modified coronal plane, you're going to be seeing like this to figure out both the lips and the nostrils. You need to presume as if you are inside mama's tummy, and that's how you need to be carefully looking at that. You don't have to worry about the list over here once you're looking at a fetal face. And I'm going to be telling you a few of the advanced things also, and you can figure out for yourself that things are not difficult. This is around 15 to 16 weeks. You're looking at orbits over there. And it always has to start off by looking at the cranium. You need to be watchful. So you're looking at your BPD, come a little lower down and you'll be able to see this. And you can always focus from here and looking at the U shape. There are going to be plenty of videos that I'm going to be showing you. The soft tissues of the upper and the lower lip and the nostrils can be delineated by what we call the modified coronal plane. The same way as when we used to go watching movies many years ago, and they used to put in a torch to show us our chin, both the lips and nostrils. That's the modified coronal plane. You can look in at the palate, and I'll tell you how we can look in for the orbits and the lens, again by various views, nasal bone by the longitudinal view, and ears when you go para-sag over there. Looking at over there. You're looking at the orbits, that's a modified coronal where you're looking at the lips and the nostrils. The nostril seen over there. Profile view, you're looking at the nasal bone, you're looking at the skin, the tip, and you're looking in at a proper. You're looking at the maxilla and the mandible. I hope the videos are working fine, Jay. There. Now, this is the end-on view where you're looking at the maxilla and the mandible and the nostrils. There, look at that. The orbits, the maxilla, and the mandible. And you need to be passionate about doing ultrasounds, and you'll be able to figure all this. There's never a problem. It's just that you need to be patient. You need to be looking at these babies very carefully. Make sure when the fetus is facing anteriorly, that's the time to grab these views. Looking at the orbits over there, looking at the nostrils there, the lips. We haven't done a 3D. This is all on 2D, and you can see all this regarding the fetal face. Profile view again, looking at the nasal bone, the maxilla, and the mandible. You can see the lips in orientation. You can see the chin is not receding. So you've been able to see there's no hyperplastic or absent nasal bone. There's no micrognathia. Maxilla, mandible, orbits, and the nostrils and both the lips over there. You're looking at the orbits. You can see this way or this way. You basically planning, we're going to be looking for hypertelorism, but you need to be seeing first is the eyeballing that you've done to see these two orbits are equal in size. There's no microphthalmia, there's no anophthalmia. Try and figure out this triangle over there. The same thing again that we're looking at. So when we're looking at the orbits and the lens, you can have an axial view of the orbits. You need to be measuring the ocular diameter, interocular distance, and the binocular distance. Basically, you should feel as if there are 3 orbits kept over there. And if the mid portion where you're going to be measuring the interocular distance, if you feel that's lesser than the orbit, then that's when you know it means trouble. Looking at the lens over there. It's supposed to be anechoic inside and echogenic outside. Measuring outer to outer, inner to inner, and inner from here to here, ocular diameter, interocular distance, and binocular distance. Now, there's something which you all should be looking at is the hyaloid artery. It disappears between 23 to 28 weeks. So if you're looking at in your anomaly scan, please don't worry. In the 3rd trimester, if you start looking at it or it's still there, you know it's going to be meaning to be troublesome. There you're looking at the lens, and you can see this is the hyaloid artery seen over there. Why I'm specifically showing this is because there's a few times when somebody sent me a patient saying there's something abnormal in the socket over there. Nothing. This is absolutely fine in your anomaly scan. If there's a failure of regression in the third trimester, that could be persistent, hyperplastic, primary vitreous, or it could be markers for trisomy 21 or retarded brain development. That's the hyaloid artery, posterior to the lens, and it's going to go over here up till the retina. For looking at the lips, the maxilla, the mandible, the nasal bone in the tongue, modified coronal view, 3D is a little more beneficial, surface display rendering, and multiplanar reconstruction, you can have a look at the malformations much better. I'm going to be showing you the malformations also just now. Looking at the lip, upper lip, lower lip, both the nostrils. Both the lips seen over there, and we're still working on 2D. Mouth open, and you can nicely see both the lips, and you can see the nasal area. Well, 3D is always a little more dramatic, always nice. You can see the nose, and then they start comparing whom the nose is going on. So we can have the axial plane for the maxilla and the soft tissue overlying it. For the nasal bone, we need a mid-sag view, the profile view. The nasal bone echogenicity should be greater than the overlying skin, and the facial profile view and the transverse view can show you the mandible, the tongue, the heart palate, and the nasal bridge. The triangle seen over there. Nasal bone seen over there. You can nicely see the lips. It's not that I've diagnosed any cleft lip over here, but at least you know the orientation of the lips is fine. The U shape over there for the maxilla and the mandible. That's the tongue over there. So if there's any macroglossia, we'll be able to figure that out. The ears, usually the ear in the near field, if outlined by amniotic fluid, readily visible. The one far field is always a little troublesome. You can have the coronal view or the parasagittal view. Any hassles, just a rescan. Never be in a rush, never presume. And if you haven't seen anything, write it in the report and mention it to the patient as well. Fetal ear seen over there. That's the ear seen over there. Now, coming on to a little more about the palate. The uvula can be visualized by ultrasound, and the echo pattern of a normal uvula, it's a typical equal sign. I've mentioned it in many of the Sono school groups as well, looking at the equal to sign. There you can see it over there. You're trying to look in at the palate, and I'll show you the equal to sign. The moment you're looking at this view, that is when you can sometimes see the tongue moving, and you can see the roof of the palate over there. So implementation of the equal sign improves the prenatal detection rate of isolated cleft palate. Again, don't be in a rush to mention it. First, you need to be looking at it multiple times, making sure before you unnecessarily give a diagnosis of an isolated cleft palate. They're now looking at over there. This is the equal to sign. You're looking at this is, so if there is a problem in the uvula, you are not going to be able to see this equal to sign because of the vocal cords on a mid-sag section through the portion in the neck, you would be able to see that as well. Just a second, Sapan. Looking at fetal orbits and face. So you can see in for hypertelorism, which I've already shown, the lens, the lips, the nostrils, and the ears. Now we start off with the abnormalities. Microphthalmia, the ultrasound appearance, you can be detected in the early second trimester when the orbital measurements are taken. There you're looking at microphthalmia. Be careful if both of them, it's a bilateral, it can be tricky, but then you'll be able to figure out that there is something wrong. Once you've done plenty of normal scans, you'll be able to figure out this orbit is normal, this is a smaller one over there. You can always measure that. Whenever there's a unilateral microphthalmia, it's much more readily seen over there. Normal orbit, and that's a microphthalmia. What else do you need to check? You need to check for sonographic stigmata of chromosomal abnormalities, looking for other facial and extremity malformations. Whenever you're looking at one anomaly, you need to be watchful. Am I seeing others? Is there any aneuploidy or not? And the prognosis varies with the etiology and the associated malformations. You're looking at hypotelorism in this. You're looking at a single nostril. The moment you're looking at a hypotelorism, please look in for the anterior portion, the forebrain. So the interocular distance and binocular distance below the two standard, this is lesser. You can see over here, it's almost equal to or lesser than the orbits. Take the measurements, and the moment you're going to peep into the fetal brain, you're going to be finding a hollow frozen kephli. Associated with it, there can be plenty. You can have a single nostril, you can have a nose which is separate, there's a single orbit, there can be plenty of things. Be watchful for that. Most commonly associated with holoprosen kephli, associated facial abnormalities you need to watch out for. Prognosis associated with trisomy 13 and 21, so looking for associated abnormalities. And prognosis obviously depends on what else am I looking at. Now, the most important aspect, and that we always and always tend to see, is when we're looking in for the lips over there. Bilateral cleft lip. You're looking at a unilateral cleft lip over there. It can be incomplete, complete, unilateral, bilateral, lateral or midline, symmetric or asymmetric. Various charts, you all must have gone through it. Basically, you need to see whether it's just a gentle cut on the lip. Is the alveolar ridge involved? Is the alar nasae involved? Are the nostrils also a little separated? And then you start going behind, trying to look in for the palate. Whether it's just cleft lip, cleft palate, or is it involving the other areas as well? Upper lip and the anterior portion of the maxilla, apart from only the upper lip, or you're looking at the posterior portion of the palate, or only the posterior portion, which is not easy to diagnose even on a reverse 3D. So just be watchful whenever we're giving a diagnosis. Cleft lip over there. Bilateral cleft lip and palate, easiest to diagnose. And you can see it on 2D as well. There you're looking at a bilateral cleft lip, and I'll tell you how do we diagnose the palate or when do we suspect it. The moment you're looking at a premaxillary protrusion, the moment you're seeing a premaxillary protrusion is when you're going to be sure of that you're looking at a bilateral cleft lip, and that's going inside the palate because the palate has given way and the whole thing has moved ahead. Premaxillary protrusion. The moment you see a profile view, you're going to be able to see that, and you're going to gradually see how much inside is it going. How much is the alveolar ridge or the maxilla giving way, and how much is the extent of the lesion. Bilateral cleft lip. Unilateral cleft lip and palate can again be diagnosed by coronal and sagittal views or the modified coronal view. There's a recent case in which I saw for a trisomy 13. I'll show you all that as well, G, just now. There, that's the cleft over there. When you're looking at on a 3D, the patient can correlate, the plastic surgeon can understand much better what are we really looking at. Now, it's not only looking at the lip. The moment I'm going to be looking at an end-on view, you're going to be able to see how much is the extent going on in the palate as well. There, that's the maxilla, and there you're looking at a break in the alveolar ridge. And then you can see it going inside. You need to just go a little superior to the tongue and you'll be able to figure out the extent. But if you see, the equal to sign is there, but you're looking at the break in the palate. Cleft lip over there. Always and always, whenever you're doing a scan, try and see how much of the alveolar ridge and the palate is involved. If somebody else has done a scan, always and always check them whether this has been taken care of or not. You're looking at there, that's the break. That's the maxilla and the alveolar ridge, and you can see the break inside. And you just have to be a little more careful watching for it, and you'll be able to see it there. The nostril seen over there. The cleft lip seen over there. Cleft lip. Both sides you're looking at trouble over there. What else do you really need to check in for? Looking in for other chromosomal abnormalities like trisomy 13, 18, 21, triploidy. Now, this is a patient who had come to me. They had got some problem in the dual term marker. So they got an NIPT done, which showed a high risk for trisomy 13. I did a scan and I could figure out we are looking at a bilateral cleft lip and palate. There was a premaxillary protrusion. There was a dandy walker malformation as well. And there was a double outlet right ventricle as well. So multiple abnormalities, and they were all pointing towards trisomy 13. The NIPT had shown a risk of 1 in 10 for the trisomy 13. There. And that's when the baby was delivered, termination done. This is what we were seeing over there. So again, you need to be looking in for the other abnormalities. You need to be looking at, and the prognosis depends on the severity of the cleft and associated malformations. Finding is isolated, obviously prognosis is good. Accompanying anomalies, then the prognosis goes poorer and poorer. Midline defects have the poorest prognosis. Be careful of the facial profile view, however adequately visualized, does not confirm a normal anatomy of lips, palate, and nostrils. So if you see a profile view, no, you're supposed to be looking at till you have done a detailed search for each and every area in the fetal face. If one does not have the time, tell somebody else to do it. But do not plan that, okay, this should be fine. We're looking at a profile view. That's what I said. You cannot diagnose unless and until you're looking at a premaxillary protrusion, but you still have to watch out for what exactly are you looking at. In this, you can see for nasal bone, and you're looking in for the micrognathia, whether the mandible is fine. This is what shows you in a profile. If you're looking at normal, you can have a flat or an absent nasal bone. You can be looking in for a premaxillary or a maxillary mass. There could be micrognathia, things like frontal bossing. You could be thinking of achondroplasia and thanatophoric. and a sloping forehead, you're going to be thinking of microcephaly. A small mandible with a receding chin, you're looking in for micrognathias. And a midline sag view is the best. There you're looking at, this is the receding chin. You can see the maxilla, barely any mandible seen. What else do you need to check in for? Congenital heart defects, skeletal dysplasias, and trisomies. If there's a polyhydramnios, there could be trouble. Intubation is always difficult. So that is why you need to be watchful for whenever you're diagnosing, and you need to be informing your doctor about it. Prognosis, again, associated anomalies, and it depends on what else are we looking in for. Now, this is something what we're looking at is nasal bone almost absent or a hypoplastic nasal bone. Hyperplasia, when we're looking at fetal nasal bone, it appears smaller. We have a spectrum where there can be an absent nasal bone, where you're looking at an absent nasal bone. The moment you go lateral and you're going to be looking at the zygoma, no, if something is pointing here, it's not going along with parallel to the nasal skin, that's not nasal bone. Be watchful for that. It could be absent, it could be a hypoplastic or a smaller one. And how do you really figure out? There you're looking at a hypoplastic nasal bone, smaller. So we have these various things that you could be looking in for. We have the 3 echogenic lines, but the other parameters which I always follow is looking for the BPD oblique nasal bone ratio. And if it's less than 11, it's fine. If it's more than 11, you definitely know you're looking at a hypoplastic nasal bone. Absent nasal bone again. So there's a difficulty in defining what do you really go. So you can have a BPD nasal bone ratio. Otherwise, you need to be looking at the charts again and again. Or you can have a single cutoff definition of 2.5. But I've seen even if it's 4 or if it's 5, it's going to be hyperplastic nasal bone when we're looking at in the later part of gestation. Small nasal bone seen over there. Then comes on to the binder syndrome. Again, it is rare, but I've seen 3-4 cases. So I just wanted to tell you also that if there ever you see a scan or you ever see this, this is what you need to be looking at. Problem of the nose and the upper jaw, where you're looking at affected individuals will have a very flat nose. You're going to be almost seeing that there is not a nose or not a nasal bone going like this, it's coming like this. It's much more flatter. I always feel the nasal portion should be going ahead of the upper lip. The moment I see this, there's a problem at the bridge over there. There you're looking at. Whenever you see something of this sort, you need to be watchful, and this is what binder syndrome or binder facies is. For anyone who's seen the leprosy patients or lepers, they almost have this where they have a flat nose over there or the flat nasal bone as such. So just be watchful whenever you're looking at such a. There you're looking at again the equal to sign, and so you're quite comfortable that this portion of the palate seems okay. Now, there's another interesting patient where I saw the ear over there and I could see a tag over there. So the moment if there is a tag and if it is discovered in a neonate, they say check for the kidneys. I always check for the kidneys in the anomaly scan or in the 3rd trimester. So I knew they're going to be asking for this. So it's specifically mentioned there. That's a tag over there, and you can see it beautifully on the 3D as well. So friends, you need to be watchful for whenever you're doing a fetal phase. You need to be having 3 views, in fact, for any of the systems, the axial, the coronal, and the longitudinal. You need to be careful of what is the anatomy over there. And the moment you've done plenty of cases, you can at least figure out there's something which is amiss, which is not normal, and then you can go ahead either yourself doing it or asking someone else to help out to figure out what exactly is the thing. So we know the fetal phase, the ultrasound mirror says it all. Thank you again, Dr. Sujit, Dr. Pardesi, sir, for giving this opportunity. And thank you for patient hearing. Thank you so much.
Thank you, Kuldeep sir. That was a very nice and elaborate talk regarding fetal phase. Each and everything has been covered very nicely. The images and videos were very informative. Thank you. Thank you for a nice talk, sir.
Thank you, Dr. Sujit. Thank you so much. Always a pleasure to be with the mock societies, because it's always a that we have these new topics that you always give us. So that's good. Thank you. Thank you so much.
Thank you, sir.
Sir, would like to ask one query regarding, shall I?
Please.
Yeah, it's regarding binder syndrome, sir. Whenever we are coming across with the isolated binder cases, do we need to go for invasive testing for that?
See, the thing is, the 3 or 4 cases that I had seen, to be very honest, they decided they're not going to carry on because they were not comfortable with it. But it's always a good idea to do the invasive testing, figure out each and everything so that the patient is more comfortable if any of them plans to carry on.
Okay, sir. Thank you.
I think so. Dr. Pardesi sir has not been able to join today.
Yeah, he's stuck with some, I think.
Must be a case or something. And Dr.
Yeah.
Sunita's thing is not working fine.
Yeah. Coming to next faculty is Dr. Archana Patil. She has done her fellowship in advanced obstetric ultrasound and certificate course in advanced fetal echocardiography. She is a lead consultant fetal medicine, founder and director Ecosonic Fetocare Aurangabad. He is visiting consultant fetal medicine at International Hospital Aurangabad, Noor Hospital, Badnapur, and Rayat Institute of Medical Sciences, Latur. She is having 8 years experience of obstetric ultrasound. She is a managing committee member of Aurangabad Obstetric Gynec Society. She is having 2 years experience as consultant fetal medicine. She is having 3 poster presentations and 1 presentation at state, national, and international conferences. She has won Best Poster Award at AMOX. She is having 3 publications under her and ongoing with textbook of fetal medicine, KEM Pune. And she is good poetess. One Marathi literature poem book has been published by her. I request Dr. Archana to start her talk.
Thank you, Dr. Sujit, for this wonderful introduction. And thanks to AMOX committee and Shield Connect for giving me this opportunity. Again, good evening to Dr. Kavita ma'am, Dr. Kuldeep Singh, and it's really a pleasure to deliver a talk regarding the basic topic after this advanced topics by the stalwarts like Dr. Kuldeep Singh and Dr. Sujit sir. So we'll proceed with the basic. So the screen. So the topic is the birthing tree. After this advanced lecture, a new baby is like the beginning of all things, wonder, hope, and a dream of possibilities. So it is banded with the birthing tree, that is the placenta, which is the basic fundamental organ in the fetal-maternal medicine department.
Sorry to
And
interrupt, ma'am.
yeah,
Can you make it full screen, ma'am?
it's full screen only.
It's not visible for us, ma'am.
But okay.
Ma'am, kindly reshare it now.
Okay. Now it's visible or still not?
It's in normal mode only, ma'am.
But here it's like, for me, it's full screen.
Okay. Ma'am, while sharing the screen, you need to click on screen window, ma'am.
Okay, fine.
You'll
We'll
get
share
a
it again.
screen window.
Yeah, sure. We'll share it again. No?
Yes, ma'am. Perfect, ma'am. Thank you.
Okay, thank you. But now my slides are not moving.
Ma'am, you need to click on the screen once. Yes, ma'am.
Yeah, thank you. Thanks a lot. Okay. So after this advanced topics, would like to switch on to the very basic topic, that is the placenta. We'll start with the quote, that is, a new baby is like the beginning of all things, wonder, hope, and a dream of possibilities. So this, the building blocking structure, that is the placenta, that is the birth tree, which is, if we look into, which will yield the good prenatal outcome, we need to redefine it. So the birthing tree. The word placenta is Latin, which come from a type of cake. The meaning of it is a type of cake is because of the appearance. Then why the birthing tree? The umbilical cord insert into the chorionic plate, and the vessels which are arising from it that traverse through the placenta further divide into the network. They form the capillaries, and there is formation of the intervillous spaces. It is in the form of a tree. That's why the birthing tree. So these structures together form the lobules, which form the cotyledons further. So with respect to the embryology, this fetal-maternal organ has two components, fetal and the maternal. The fetal component that develops from the chorion frondosome, and the maternal component that develops from the deciduo apicales from the endometrium itself. Structure. In humans, the placenta measures about 22 centimeter in length, and the thickness varies from 2 to 4 centimeter, which is high at the mid portion of the placenta and which is lower at the edge of the placenta. And the weight is about 500 grams. It grows at the rate of 1 millimeter per week. So we can calculate the gestational age in terms of weeks if we do the placental thickness in millimeters plus 10 millimeters. Then there is a difference in between the thickness of anterior and the posterior placenta. The anterior placenta is being 0.7 centimeter or the 7 millimeter thinner as compared to the posterior placenta, which is the normal variant. So this placental structure, it is thick in various conditions, like it can be normal, then in fetal macrosomia, fetal hydrops, then torch infections. Few maternal conditions are also associated with the thick placenta. These are the maternal anemia and the maternal diabetes. Then whenever the thick placenta with cyst we are coming across, then we need to look or we need to think about the partial molar pregnancy, triploidy, then placental mesenchymal dysplasia. The placental appearance is thin in few cases of preeclampsia, then placenta membranacea, which is the very rarest form, and of course in the polyhydramnias because of the pressure changes. When it comes to the functions, I'm going to be a bit in physiology of the placenta. So the placenta and the umbilical cord itself forms the transport system for the mother and the fetus, where exchange of the nutrients, gases take place. So the placenta performs the function of nutrition and excretion as well, which occurs through the active and the passive transports, wherein the fetus receives the nutrients and oxygen and the waste products and the carbon dioxide that is thrown into the maternal blood. So if there is an increase and decrease in amount of nutrients or the supply of the other transporters which are there in the system, it may cause the overgrowth or undergrowth, that is the growth restriction in the baby. So another function is the immunity. It acts as a selective barrier, but few viruses are there. They can cross the placenta and cause the fetal infection like rubella, Zika, and the CMV. Then endocrine function, we are a bit familiar about the HCG role of progesterone and estrogen in case of placenta. So I'm going to deal with the human placental lactogen, which is really coming into play in the role of fetal metabolism and the growth development of the baby, which is an act on the lactogenic receptor to modulate the embryonic development in the baby. And increase in human placental lactogen is seen in multiple pregnancies. In that, molar pregnancies, diabetes in the RH incompatibility, and decrease in human placental lactogen can be seen in toxemia, cholangioma, and the placental insufficiency. So the immunological barrier, it can be formed, one of the function of the placenta by means of secreting the neurokinin containing phosphoprotein molecules. There are various types of the placenta which can be categorized according to the anatomy and the structure, again, and the cord insertion. So the anatomical classification, it can be posterior, anterior, fundal, left or right lateral placenta. Again, according to recent guidelines, we are classifying the placenta as a high or low, that is away from the internal os, close to the internal os. Grading is now obsolete in the ultrasound scan. Till date, according to as being a product of Fernandez, we're not doing the grading over there. So I do prefer that thing in ultrasound scans. Right now as well, I'm not going to prefer the grading of the placenta. So in concern with the low-lying placenta, whenever the placenta is 2 centimeters away from the internal os, we are taking it as a low-lying placenta, but the recent ISO guideline states that if the placental lower edge is 5 millimeter apart or distant from the internal os, it can be taken as the low-lying placenta. It's because whenever we come across the finding that is the placenta is low or 2 centimeter away from the os, we need to perform a repeat ultrasound at 34 weeks of gestational age to localize the placenta to judge the placental localization. But it was associated with increase in number of scans. So right now, due to the study and the evidence states that now the distance for low-lying placenta is considered to be 5 millimeter away from the internal os. Then structure differences are there. According to the structural differences, the placenta can be classified into circumvallate, circummarginate, bilobed, and succinturate placenta. Again, the scans I perform daily basis right now since 2.5 years I'm practicing as a fetal medicine. The only form I'm getting very often in our area is a circumvallate placenta, and it is a bit associated with the fetal growth restrictions. So whenever we come across such circumvallate placenta, we need to advise that the patient should have serial growth scans starting from 28 weeks onwards. So depending upon the cord insertion, it can be central, which is very common thing, then marginal and the filamentous cord insertion are there. We need to see it for and we need to report in our report. So the clinical significance of the placenta. So these are some pathological conditions and the you can see complications of the placental things. So we are dealing with now. This is the cholangioma. So here we need to differentiate this cholangioma from the placental cyst as well as the subamniotic hematoma because of the location and the appearance. Again, the cholangioma can be differentiated from those of these two conditions by means of presence of vascularity. Again, if the vascularity it is present, we need to justify whether it is an arterial supply or the venous supply. As if the supply is an artery, then we need to think of the complications like anemia, then cardiac failure, which can be present in the fetus due to the arterial supply. So this is the placental cyst. Again, just where we have gone through the cholangioma. Then here is the placental cyst. You can see the difference that by applying the color, this is the avascular structure. There is no blood supply or vascularity seen in that particular section. Again, the diagnostic ultrasound finding of the placental cyst is the presence of fibrin deposition, which is seen only in the placental cyst. So why we need to see about the placental cyst? Because the presence of placental cyst may be associated with the FGR in the baby. We need to monitor those babies for the development of FGR. Again, the scans from 28 weeks, that serial growth scans, are recommended in those cases. This is the entity morbidly adherent placenta. Now the termination we use for that is the placenta accreta spectrum. So we can justify it on the ultrasound itself, one of the common modality because of increasing surgical interventions. So we need to look for in 2D ultrasound for the retroplacental area. Sorry. Here, the vessels seen traversing to the placenta to the bladder serosa. Again, when we put the color, we can justify these vessels, they are present, which are invading the serosa. This is the power Doppler image, that is power angio, which is showing again the placental adherence, or you can say placenta accreta spectrum. We need to justify and diagnose the condition as it is. It may be life-threatening if we won't diagnose it on the ultrasound. So the diagnosis can be confirmed if we are not sure regarding the focal things. Whenever if we are just suspecting that there is a part of vascularity seen, that is in case of a focal placenta accreta spectrum, we need to go with MRI, supportive MRI, to diagnose the entity. Placental abruption, that can be also diagnosed on the ultrasound. That is the peculiar form of it is it always look like a crescent, like retroplacental space or swelling, you can say, under the retroplacental area. The first, or in the acute cases, it may be seen as a transparent or anechoic area. Again, the organization of the hematoma may cause it's an iso appearance as like that of uterus, and after the organization, it may look at hyperechogenic. So these are the references. Thank you for patient listening.
Thank you, Dr. Rachana. That was very nice talk. Placenta is something what is basic thing for obstetricians and sonologists. So you have covered normal and abnormal things very nicely.
Thank you, Dr. Archana. That was really in detail talk about.
Dr. Sunita, the connection is unstable. We're not able to hear you properly.
I think she has lost her connection.
Ji.
So, okay. I think with this we'll wind up, I think. Anything suggested, sir?
Nana, this is fantastic. In fact, it's always good to have these systems because then people understand what has to be done over there. So this was very good. Dr. Archana took over the placenta, which is again a topic which nobody wants to read, but it's always very important. You took all the things on the thorax very, very nicely because one needs to be aware of, okay, these are the newer things that have come, the LHR ratio, the CVR, the congenital airways, the pulmonary ratio, which is very, very important because the moment one sees it, they say we do not know how to prognosticate it, so just terminate. Termination is not the answer. With so much of progress happening, we're diagnosing much more earlier thanks to the machines getting advanced. So let's do that so that then we rather than saying for termination, we can always say just keep the baby. These are the parameters. I've in fact day before yesterday only saw a one with the CPAM and they were all for okay, this is something and it's an IVF pregnancy. conceived after 20 years. So
Okay.
told them not to worry, things are going to go fine. And before even starting the scan, because somebody had discovered at 20, I said, I'm doing it at 22, it's going to increase in size. So do not worry. We're going to calculate the CVR, and by 28 weeks, it's going to start reducing. That's fantastically mentioned by you also. So once we have these the informatory webinars where they know which system, and overall review is always good, but for specific systems, it's very nice, very, very nice. And Dr. Archana, you did a fantastic job putting up the placenta. That's nice, very nice.
Thank you, sir. Thank you for nice words.
Thank you, sir, for the appreciation.
Thank you.
Sunita, are you there? Again, she has lost.
There must be, it's an unstable thing. I think so. She was having this problem right from the beginning itself. Sometimes these Wi-Fi things can really go a little haywire. Yeah, there, Dr. Sunita is back again.
She is there.
Sunita.
Yes, sir, I'm there. Hello?
Yes.
Ma'am, your voice is breaking, ma'am.
Dr. Sujit, why don't you do the bye-bye and then we all catch the bus and go back home?
Yeah, that's a better thing. Okay. As again, she has lost. Final thing is the vote of thanks. Thanks a lot, our chief guest today, Bapat ma'am, for giving some guidance here. A lot of thanks to our esteemed faculties, Kuldeep sir and Dr. Archana. Very, very nice, wonderful, informative talks. And thanks to all delegates who have joined with their impending OPD. And big thanks to Shield Healthcare and to Stalin and Sanhita for giving the technical support. Thanks a lot once again. With this, we end this session.
Thank you. Say my hi to Pardeshi sir, otherwise I'll text him as well. Please do.